Hello and good day. Welcome to the closing plenary session of APICS 2020, and we hope you have enjoyed our program over the last 1.5 days. My name is Jensen, and I'm an anesthesiologist and intensivist at the Tan Tock Seng Hospital in Singapore. And today I have the great honor and privilege of moderating this session. Before I introduce our speaker, let me quickly remind everyone that you may key in your questions on the Q&A function of your Zoom screen, and we will address them at the end of the session. In our closing plenary for this conference, we will be addressing research in COVID-19 and what it means in your clinical practice. It gives me great pleasure to introduce my good friend, Prof. Andrew Woody from Australia. Andrew is a full-time intensive care clinician and researcher at the Alfred ICU, Melbourne. He completed his undergraduate medical education at the University of Auckland, followed by ICU training in New Zealand, the United Kingdom, and Australia. After a award of fellowship, Andrew worked as a consultant for many years in Queensland, while also completing a PhD in antibiotic pharmacokinetics. His major academic interests include optimized drug prescription in the critically ill, hemodynamic management in severe sepsis, acute kidney injury and renal replacement therapy, management of SAH and traumatic brain injury, and critical care nutrition. He is also involved in critical care research internationally as the secretary of the NZICS Clinical Trials Group, and he is also a keen educator, instructing on BCLS, ALS, ECMO, ENLS, and EMSD courses. He is also the chair of the Neurocritical Care Special Interest Group, College of Intensive Care Medicine. Andrew is co-deputy director of the Australian and New Zealand Intensive Care Research Centre, Monash University. So clearly he's very well placed to talk to us about research in COVID-19. Andrew, the floor is yours.
Thanks very much, Jensen. I'll just share my screen and we can start. Okay, well, so thank you very much, I guess, first of all, for the opportunity to deliver the closing plenary for the symposium. It's a great privilege, so thank you, Jensen, and to the organising committee. What I'll do is I'll just quickly give a brief outline of what I'm going to talk about, and then after that, just go through the talk in more detail. First thing I really wanted to do, though, however, was to provide just my disclosures. I am a member of the SPRINT-SARI Australia Management Committee, which is a prospective observational study being undertaken here in Australia, looking at PCR positive COVID-19 patients admitted to ICUs. And I just wanted to acknowledge the support of the Department of Health of the Government of Australia, which has funded this project and has allowed this work to take place. I really just want to break down my talk to talk about COVID-19 research more broadly, provide a little bit of commentary about how data has been generated and disseminated, talk a little bit about some of the demographics and risk factors of patients that have been get admitted to ICU with severe disease, and then focus a little bit around treatments and outcomes. And in particular, I guess I'll just say at the outset, what we're going to talk mostly about is in-hospital outcomes or 28-day outcomes. And we really don't have a lot of information about survivorship and what that looks like for patients with severe COVID-19. And I think that's going to be a really important high priority area for ongoing research in this space. First thing I guess I just wanted to touch on was really just the volume of information that has been generated around COVID-19. So these authors just looked at the number of unique documents which were indexed in Web of Science or Scopus through to 30th of June 2020, and they searched for articles pertaining to COVID-19. And they were able to identify over 23,000 unique documents. 10,000 were common to both databases, but that just gives you an idea of the number of publications now, and that's only to the end of June. So current estimates would suggest that probably now to the end of October, there's been more than 60,000 individual publications on COVID-19. So there is this tremendous volume of papers that have been generated around this condition. And if you then look at the same paper and you look at the actual different types of journals that are publishing these work, these are some of the high impact journals, that are more prestigious journals, as well as lower tier journals. So it's not just this lower tier group of journals of publishers that are churning out this work. It's some of our higher impact journals as well. And I think this obviously does reflect a commitment by the publishers to disseminate information more broadly and more widely, so that it gets out there to the clinical community. And I think that obviously can be a good thing. However, there's also been that this information has been disseminated at really what is quite an extraordinary pace. These particular authors simply looked at searched PubMed with the search term COVID-19 for the period 30 January to 23 April 2020, and they extracted from those papers data pertaining to dates of submission and then acceptance, and then just worked out, well, how does that time frame vary? And they were able to identify that for COVID-19 papers, the median time from submission to acceptance was 6 days, whereas if you look at there for something like cardiovascular disease, it's 102 days, and it's typically much longer for non-COVID-19 related research within those same journals. So I think that this really reflects that there's been both an increase in the absolute number of papers that have been published around COVID-19, and it's really occurred at really quite an extraordinary pace. And then on top of this, of course, there has been a significant social media overlay with the utilization of a large number of platforms to allow the dissemination of this material, either unfiltered or with some degree of commentary, but it obviously can reach dramatically around the globe. And then on top of that, we have this politicalization, if you like, of COVID-19. There is a substantial political overlay and a mainstream media overlay. And just, that has really, I think, probably provided a lens through which a lot of the broader community have received COVID-19 information. And this has been around treatment options, around resourcing, around ICU bed availability, healthcare worker infection, staff protection, etc. And on a personal note, I've never really seen another scenario where we've had a condition that principally affects ICU that has had this narrative around it. But I think what this has led to is that there has been this tidal wave of information that has been confronting the individual clinician, whether it be through mainstream media, whether it's through social media, whether it be through traditional publishing pathways or otherwise. And this has been quite burdensome for the individual clinician to wade through all of this information to try and to determine what is the optimal process of care, what are the optimal treatments that I should be utilizing for COVID-19 patients. And there have been lots of different responses to this. And in a moment, I'll take you through what's happened in Australia. But it has been quite interesting really to look at the way that some of this information is disseminated and being utilized via the clinical community. So this is just some data from Symposium Australia, and it's still currently under review, so I'd appreciate that it's not disseminated any further. But we simply looked at the utilization of corticosteroids, both in terms of an absolute number and then the proportion of patients that these are severe COVID-19 patients admitted to ICU in Australia. And we looked at the utilization of corticosteroids both before, after the preprint release of recovery, and then after its formal publication. And what you can see there is really in a quite a striking way is the fact that there was this significant uptick and almost wholesale change in the prescription of corticosteroids almost overnight after the preprint release of recovery. And I think that this is a reflection of the fact that clinicians had a lot of appetite to try and utilize something that would improve outcomes of COVID-19. Also, dexamethasone, I think, is largely viewed as being a drug which has limited side effect profile. limited cost implications, is sort of devoid of any significant harm. And as a consequence, I think there was this wholesale sort of change in practice. But arguably, this was just a preprint. It wasn't actually in a peer-reviewed journal yet. And of course, the data was from a different healthcare jurisdiction. And then what we can see is, of course, that this peril to this pace of publication, this rush to publication, does have perils. Of course, everyone will be well aware of the Surgisphere debacle and the fact that highly questionable data ended up being published in a really high impact, prestigious journal, and it had a real impact upon an ongoing clinical trial in severe COVID-19 patients. So I think this is a really salient lesson for clinicians about ensuring that we really look and dive deep into the provenance of data and consider what this means for us in a local context. And in fact, this is just some data which I think reinforces this, from Giovanni Landoni and colleagues from Milan, where they looked at the death rate at 50 days after at least 0.1 deaths per million inhabitants from COVID-19, and compared that to on the y-axis, on the x-axis, the starting day of the epidemic in varying regions of the world. And you can see there, first of all, that there's substantial heterogeneity, huge amounts of variability in the mortality burden. Also, that perhaps for those areas of the globe that were exposed to the pandemic later, they actually had improved outcomes, possibly related to improved preparedness, public health interventions, etc. But this just really reinforces to me that what you need to ensure is that you consider interventions within the context of local data. And I think that that's really important, particularly when you consider that a lot of the trial data that we're going to talk about have actually been generated in areas where there's been a high mortality burden and during varying phases of the pandemic. So in Australia, we've been really lucky. Quite early on, the Australian New Zealand Intensive Care Society decided that we needed to have some national guidelines around the management of severe COVID-19 related to both treatment, but also how to set up and how to optimize the processes of care and delivery of care. And in addition, the National COVID Clinical Evidence Task Force was mobilized very rapidly to critically appraise new data, to synthesize it, and to generate a sort of living guidelines for the management of mild, moderate, and severe disease. And they've been able to generate these clinical algorithms relating to both disease-modifying therapy, but also, for example, to ventilator management of patients with COVID-19 that utilizes the most available up-to-date data, and in fact, actually, typically within 1 to 2 weeks of new trial information hitting the broader community, these guidelines will tend to be updated. And I think that the rapid mobilization and the resources that have been employed have really helped to shape the response in Australia. Now that just completes the first part of the talk. What I wanted to do now is just talk a little bit about demographics and risk factors for severe disease. And I'm going to show you some data from the SPRINT-SARI Australia project. This is something which has been 10 years in the making, really since the H1N1 pandemic, a collaboration between ISARIC, the ANZIC CTG and Monash University. And really it's just a widespread prospective observational cohort study of severe COVID-19 patients admitted to ICU in Australia. We have published some data from the first wave of the pandemic in Australia in terms of ICU resource utilization, and a little bit about demographics and outcomes. This was for the period 27th February to 30th of June 2020. The peak occupancy in terms of ICU beds was in early April, and this is a total cohort of 204 patients. The demographics for those patients with severe disease needing admission to ICU, this won't be a surprise to many people. Here we've got data both from phase 1 and phase 2, and this is still being curated and being considered. So again, I'd appreciate no further dissemination, but it shows that, and this won't be a surprise, that patients that are being admitted to ICU with more severe disease have this metabolic syndrome consistent with diabetes, obesity, and chronic cardiovascular disease. And that's quite similar to other reports from the sort of global literature. If you look at the age and sex distribution, you'll see that 2/3 of the patients will be men, and the burden of the disease tends to be in an older age bracket above 50, 55 years of age. but outcomes, in fact, actually from this cohort were really quite comparable, quite favorable compared to some of the reports from other areas of the globe. An overall mortality of 15%, 22.2% in those that were mechanically ventilated, and an ICU length of stay, a median ICU length of stay in those that were mechanically ventilated of 16 days. And this, I think, was really a salient bit of information for the ICU community within Australia, which was that if we could maintain resourcing, if we could maintain availability, and we were committed to these protracted periods of time in ICU, you could still achieve really quite good outcomes for patients with severe disease within Australia. What I'll do now is I'll just pause there, and what I'm going to do is go on to talk a little bit about some of the treatment options and that are available to us and some of those data. And I think the first thing we have to do is to really congratulate the recovery investigators. This was just a tremendous undertaking and an endeavour led by a group at the University of Oxford in the United Kingdom, which was a large multi-centre platform trial of varying therapies related to COVID-19. And it was an especially difficult time to undertake this work within the UK. And as a consequence, I think they really do need to be congratulated. And a lot of the recovery data have really changed practice globally. The dexamethasone story, again, I won't take too long to talk about this because most people will be familiar with it. But of course, recovery randomized hospitalized COVID-19 patients to either 6 milligrams of dexamethasone IV or oral for 10 days or to usual care. This is an open label, not a placebo-controlled study. 25% didn't have any respiratory support, 16% were invasively ventilated. The overall absolute risk reduction was 2.8%, remembering that in the control arm, mortality was actually quite high. It was above 20%, remembering these are hospitalized patients. But it did suggest a fairly significant benefit with the use of dexamethasone. And then this was combined with other studies in critically ill patients to inform a meta-analysis of, this included 1,700 patients. There was 57% of the weighting of the analysis was from recovery, which included their invasively ventilated cohort. And it demonstrated, I think, what is quite a robust finding in terms of the benefit from corticosteroid exposure in patients, in critically ill patients with COVID-19 in terms of 28-day mortality. And so I think that that's a fairly solid finding. And I don't think that too many people are going to I guess, debate the likely benefit of corticosteroids in this cohort, although I think we do have to identify that the majority of the data comes from the UK, where there was a high mortality burden and it was relatively early within the pandemic. The recovery investigators also went on to have a look at a couple of other potential therapeutic interventions, namely being an antiviral agent, so lopinavir, ritonavir, where this was an orally administered therapy only, randomized to that therapy or placebo for up to 14 days. 4% of that cohort mechanically ventilated. There was no significant difference in 28-day mortality. Again, note the high mortality overall, I suppose, for the cohort. They also looked at hydroxychloroquine, used quite a high dose, 800 milligrams initially, 800 milligrams 6 hours later, and then 400 milligrams 6 hours after that, followed by 400 milligrams BD for 10 days. 17% of that cohort mechanically ventilated, and there was no benefit from hydroxychloroquine. And in fact, when you looked at a composite outcome of mechanical ventilation or death, that was actually a higher proportion of those patients that received hydroxychloroquine had that outcome. So I think these again are relatively robust findings. I don't think we'll get a lot of extra or additional evidence that suggests that these therapies are going to be beneficial in severe patients. Now, the Remdesivir story, of course, this is just the Act 1 trial that I think many people will be familiar with. So this was a multi-center randomized controlled trial, double-blind, placebo-controlled, enrolled 1,000 hospitalized COVID-19 patients. It's IV therapy only, and they randomized to get either 10 days of therapy or placebo. 64% were men. Median age was 60 years, and patients had a median duration of symptoms of 9 days prior to enrollment and randomization. Now, interestingly enough, the primary outcome was time to recovery, and we saw, and the authors reported here that this was shorter. It was a median of 10 days with remdesivir versus 15 days in the placebo group overall. The Kaplan-Meier estimates of 28-day mortality were 11.4% in the remdesivir group and 15.2% in the placebo group. But interestingly enough, there was baseline imbalance. In fact, that the more patients in the placebo group were actually receiving mechanical ventilation or ECMO at baseline. And I wonder if that, in fact, actually is reflected in that 28-day mortality difference. And certainly you can see here, when you look at the subgroups, there really wasn't a strong signal towards remdesivir being significantly beneficial in patients with more invasive needing more invasive respiratory support. Although the authors were at pains to say that in those that were receiving mechanical ventilation or ECMO at baseline in the remdesivir group, they had a shorter duration of therapy. And if you weren't receiving those therapies at baseline in the remdesivir group, a lower proportion went on to need those therapies. Now, of course, the Solidarity study has recently been released as a preprint publication on medRxiv. This again was a tremendous undertaking. A WHO-funded study, open label, pragmatic, platform trial, looking at a number of different study interventions for COVID-19. It enrolled and randomized over 11,000 patients in 405 centers in 30 countries, in a lot of sites that hadn't actually already hadn't previously contributed to COVID-19 trials and COVID-19 research. And I think as a consequence, this study has actually got significant external sort of validity or generalizability as a consequence of that design. Now, the overall Kaplan-Meier estimate of 28-day mortality overall was 12%. And you know, the take-home message here was that none of the study interventions that were looked at, remdesivir, hydroxychloroquine, lopinavir, ritonavir, or interferon, were associated with reduced mortality, initiation of ventilation, or duration of hospitalization. You know, this is, you know, obviously at odds with the ACT-1 study. And so the Solidarity investigators undertook a meta-analysis where they combined the ACT-1 data with the Solidarity data, and they looked at an overall estimate of treatment effect. And here you can see that overall, there was no association no significant association between the use of remdesivir and a reduction in 28-day mortality. They looked at some subgroups there, so a lower risk group, lower risk of mortality, those without ventilation versus a higher risk group. And you can see that there's potentially some divergence in terms of favoring remdesivir in the lower risk group versus favoring control in the higher risk group. But I think that the individual clinician is going to have to sort of consider these data. On the one hand, we've got a multi-center, double-blind, placebo-controlled, randomized controlled trial. This was a very large, highly generalizable, pragmatic study undertaken in numerous centers across the globe. And certainly for me, my take-home message is I think that there really isn't a strong signal for remdesivir being particularly helpful in patients that are mechanically ventilated in the ICU with severe COVID-19. This is a more recent study, which was just recently published in relation to tocilizumab, of course, an interleukin-6 receptor antagonist. There was a multi-center, double-blind, randomized controlled trial, which compared the study intervention versus placebo at a dose of 8 milligrams per kilogram of tocilizumab in hospitalized COVID-positive patients who had to have a raised inflammatory marker, +2 of either fever, pulmonary infiltrate, or supplemental oxygen. Now, patients were excluded if they were receiving greater than 10 liters of oxygen. The primary outcome was the time was either requiring intubation or death, and here there was no difference out to day 28, and here there was no difference. Now, there's been a number of other therapies that have been proposed, I suppose, for how we might be able to treat and improve outcomes with severe COVID-19. But I really think that there isn't necessarily going to be a single magic pill or magic bullet, which is in fact actually going to treat all of our patients with COVID-19. There are a number of other therapies that are being investigated here in the National Living Guidelines. Don't recommend the use of any of these agents outside a clinical trial because they're still under investigation. One thing that I think is, however, really going to be of clinical interest is the role of therapeutic anticoagulation. Many people would have seen these data about the post-mortem findings in patients with severe COVID-19 who are ventilated. And I think that we don't really know what is the role of therapeutic anticoagulation, but this will remain a really high priority because I think that there is a degree of clinical uncertainty. Probably the next thing is, well, you know, how should we really ventilate patients in the ICU with COVID-19? Is this simply a matter of extracting, extrapolating ARDS data? Is COVID-19 a subgroup of ARDS? And the answer is I really don't think we know. Certainly severe COVID-19 would meet the Berlin criteria for ARDS. And there have been a number of studies that have been published over the last 2 decades, which have tried to inform best practice for managing patients with severe ARDS, from low tidal volume ventilation all the way through to ECMO. And certainly a lot of that data has been extrapolated into COVID-19 patients. From Symposium Australia, we know 40% were receiving neuromuscular blockade, 25% were being prone ventilated. But we don't have robust randomized controlled trial data to actually support any particular intervention in the management of patients with severe COVID-19. Instead, what we have is some really useful information from areas of the globe that have had to ventilate large numbers of patients with COVID-19. And this particular narrative from the group in Milan, I think, was incredibly helpful to allow us to tailor therapy, to nuance therapy to the patient in front of us. And I think a major theme around this was trying to prevent patient self-induced lung injury by avoiding that powerful respiratory effort that some patients will have, so thereby reducing shear injury to the lung and vascular stress. And then after the patient is intubated and they're receiving mechanical ventilation, really trying to quantify their compliance and determining whether or not they're able to accept higher tidal volumes and use a lower peak, because the issue is really hypoxemia. Whereas in scenarios where compliance is diminishing, you would tend to sort of utilize a more traditional ARDS sort of respiratory strategy. But it's really this information which I think allows us to tailor the approach, and doing the basics well, I think, is going to be a key strategy for maintaining high quality outcomes with mechanically ventilated patients. Another highly topical area, of course, is the aerosol generating procedure and how we can best protect our staff and healthcare workers. This is, again, heavily politicized, and there's a lot of a mainstream media overlay. There is no definitive evidence on the optimal PPE, but it goes without saying that I think that we want to offer our staff the highest degree of protection possible within the resource constraints within the local healthcare setting. And there have been a lot of attempts to try and provide solutions to fit all settings, but this is going to have to be tailored to what is available at your institution and a number of human factors. I think from this point of view, it's been really useful to look at the historical perspectives from areas of the globe that have already been managing patients through a respiratory pandemic. And this particular paper from the Asian Critical Care Clinical Trials Group, I think, was incredibly useful for the Australian and New Zealand ICU community to look towards, to think about how we're going to manage this in our area, looking particularly at processes of care. And I think utilizing a hierarchy of controls has been incredibly useful, whereby the top tier has been trying to eliminate the actual disease in the broader community, and a number of systematic administrative controls to try and avoid nosocomial infection. I think that the key thing here is that in order to try and maintain the highest and highest quality and the best outcomes for severe COVID-19 patients really relies on maintaining a healthy workforce, nursing staff, ancillary staff, allied health staff, medical staff. And so we really want to try and focus on that. And then that is, in fact, actually, I think, going to be one of the key aspects to maintaining good quality clinical outcomes in your region. In Australia, we've been very lucky because the burden of disease has actually been relatively low. And this is actually a reflection, I think, principally of the public health interventions that have been enacted in Australia. And part of, I suppose, part of the COVID-19 narrative is to realize that it is a communicable disease. And so as a consequence, I think for us in the ICU community, we have a responsibility to help to try and reinforce that messaging with the broader community, that if you adhere to and you enact some of these public health interventions, that will result in a reduction in the broader transmission of disease and broader transmission of disease, and as a consequence will therefore enable you to maintain adequate ICU resourcing. Just seeing, I'm not sure what's happened to this last slide of mine, but really this was what I was going to say here was that the key thing in this respect was in terms of looking at the effect of public health interventions on the wider community. In fact, if you actually look at the effects of, or if you try and plot GDP versus, sorry. Sorry, I'm just Sorry, I'm just trying to stop sharing my screen. I'm sorry there, guys. I'll have to get this back. Sorry, I've got a bit of a technical problem there. I wonder if the group there in Singapore could just stop sharing my screen. There we go. Thank you very much. So I'll just finish there. What I'll say is that the thing there was that when you look at growth in GDP and you try and map that against the overall mortality burden for regions, you don't see the relationship that you might expect, which is that there has been a greater reduction in GDP in those areas where there has been a low mortality burden because of all of the strict public health interventions. In fact, if anything, you tend to see that in those areas of the world where they have used strict public health interventions to reduce broader community transmission of COVID-19, that's actually been associated with a lower mortality burden. So that just reinforces to me, and I think is food for thought, that if we try and promote a safe, healthy, broader community, that in fact actually has the greatest impact on the actual economy. So I'll leave it there. Thank you very much. I'm sorry my slides didn't quite turn out right there in the end, but you can contact me at andrew.udy@monash.edu if you have any questions. And thank you once again, Jensen.
And spotlight me. Thanks very much, Andrew. I must say it was an excellent presentation. You've covered so much ground in a short span of time. So I think we'll have some time to take questions as a result of your spinning through your slides and giving us some space at the end for Q&A. So my first question is regarding the information and how it gets adopted and how quickly it gets adopted. For example, you mentioned in the recovery trial, there was actually the press release or preprint before the publication of the actual peer review paper. And as confirmed in your data that you showed from the Sprint Seri group, that there was indeed widespread adoption of the use of systemic corticosteroids long before, maybe 1 month before the actual peer review paper was published. And for example, in the case of Remdesivir, we have had politicians weighing in, we have had conflicting somewhat results and conclusions from the pharma-sponsored studies versus the studies by non-profit entities. So the question is, what threshold should we have before we adopt any of these new practices? And I think that ties in with one of the questions by a Dr. Irwan, who asked, in many research data and published studies on COVID-19, how do we differentiate the good studies from the bad studies?
Yeah, it's an excellent question. At the end of the day, the individual clinician is going to have to make an assessment on the basis of the data. But there's no doubt that I think the pandemic has totally changed the way that medical information and data from large randomized controlled trials is disseminated. This is the first time that I've seen these major findings put out in a press release. And as you've already mentioned, that sort of, I guess, dissemination has led to almost immediate translation in clinical care. And I think it relates to a number of human factors. As I mentioned, there was a tremendous appetite to find something that would help with COVID-19. And it was relative, dexamethasone considered a relatively low risk intervention. I don't think there would have been as rapid translation if the intervention had had higher cost implications or had a potential harmful side effect profile. But dexamethasone, I think, was considered to be relatively safe, and so therefore it was rapidly translated. I think what it comes back to is, for me, I think that as an individual clinician, you need to yourself to be satisfied with the provenance of the data. First of all, you need to look. I think, are you satisfied that it has been generated in a robust fashion? I would then also utilize local guidelines, particularly, for example, here in Australia, the National COVID-19 Task Force has been amazing in terms of appraising the data, considering its validity, and also its applicability within our local healthcare context. And so that, and that is really a national resourced body which has generated these guidelines. So I think that's the way that I would approach it. I think you need to make your own informed decision. I certainly wouldn't just rely on sort of media statements. And secondly, I would look to guidelines from national bodies to help inform your clinical decision making.
Thank you. So I think that what we're seeing is new methods of information dissemination, not just like in press releases and also from social media, as opposed to more traditional forms. For example, the journals, peer-reviewed journals, and also in-person scientific meetings. So my next question is, as a means of dissemination of scientific information, we've seen many conferences which were previously in-person conferences going completely virtual. So do you think there is still a role for the in-person live scientific meetings moving forward?
Oh yeah, absolutely. I definitely think so. I mean, you know, the virtual meetings have been fantastic, and this has been a great example of one that still allows us as a community to connect. And I think it's, you know, I just acknowledge the efforts of the organising committee to put this on. I think it's brilliant. You know, over a very challenging time. But there's no doubt that I think that being able to network personally, have a face-to-face conversation with colleagues and peers from other areas of the globe, I think there is a certain unmeasured satisfaction that I think that people get from that, and that it results in more dialogue, more collaboration, and a more global, I guess, view of treatment, particularly during a pandemic. So I think that hopefully once we're through COVID, I would hope that we will return to some of these in-person meetings. You know, the translation of rapid translation of data from clinical trials into medicine and the utilization of social media platforms and infrastructure, it's a fantastic you know, observation. There's definitely a place for these pathways, and I think rapid knowledge translation, in particular in ICU, is something that we have lacked in some ways for certain therapies. You know, and so it is important that we get this knowledge out there, we get this data out there, so that it can be considered by the wider community. But I guess there's just salient lessons for individual clinicians and for administrators and for peak bodies to really scrutinize the data, to think about it, put it into context, and then make an informed decision, rather than just perhaps relying on a you know, a 280 character tweet or something like that. I think it's important to really get the source data, to get the source documents, and to consider it before the wholesale sort of changes in practice.
Okay, thanks, Andrew. We have a few more questions, but unfortunately, I think we do not have the time to go through them. Perhaps you would like to, I mean, for those of us who have questions for Professor Woody, you may reach out to him via his email address that he had shared previously. And I think that brings us to a fitting conclusion to say that online conferences seem like they are here to stay, even as we look forward to the day that we can once again meet in the flesh with each other once all of this blows over. I would like to take this opportunity to share that SG and ZICS will be making a comeback in 2021. And if you didn't already know, SG and ZICS is jointly organized by SICM and our Australian, New Zealand counterparts, NZICS. We've always had an excellent partnership, and I think this was nicely exemplified by Professor Woody gracing our closing plenary today. The plans are still fluid, but it will probably feature an online component as well as a live meeting to the extent allowed by the prevailing circumstances next year. So please follow SG and ZICS and APICS on our social media accounts on Facebook and Twitter to receive latest updates. And once again, I want to thank Professor Andrew Woody for his fabulous closing plenary. And I want to thank all the delegates, and it has been a pleasure having you with us over the past 1.5 days. Thank you also to our sponsors, without whom this event would not have been possible. And this wraps up our very first APICS conference. See you soon at SG and ZICS 2021, and have a good weekend, everybody.
Thank you.